Dr. Ozan Karaman. I'm one of the co-founder and chief scientific officer of Bonegraft Biomaterials. I'll be trying to assist our speakers today. I would like to welcome you to our webinar entitled Predictable and Simplified Implant Rehabilitation and Bone Regeneration in Everyday Practice. Each of our speakers will have 40 to 45 minutes of presentation, and we will have questions and answers section at the end of the second presentation. It's my pleasure to introduce our two valuable speakers, Dr. Minas Leventis and Dr. Emmanuel Skalidis. Our first speaker will be Dr. Minas Leventis. He's an internationally recognized oral surgeon and implantologist with over 25 years of clinical teaching and research experience. He holds an MSc and a clinical specialty in oral surgery, as well as a PhD in oral pathobiology from the University of Athens, with advanced postgraduate training in periodontics and implantology from the University of Heidelberg. Based in London and Athens, Dr. Leventis has performed over 10,000 surgical and implant procedures with particular expertise in bone grafting, tissue regeneration, and complex surgical cases. A sought after international speaker, Dr. Leventis has lectured in over 30 countries and has published more than 40. See, there's 40 scientific articles in international peer-reviewed journals. He is a full member of the British Association of Oral Surgeons, a fellow and diplomate of the International Congress of Oral Implantologists, and a visiting lecturer. Sorry, and a fellow of diplomate of the International Congress of Oral Implantologists and a visiting lecturer at the ICE Postgraduate Dental Institute in Manchester, UK. Our second speaker, Dr. Emmanuel Skalidis, a graduate of Plovdiv State Medical University with extensive clinical experience, including dental practice in Greece from 1998 to 2019. Since 2019, Dr. Skalidis has been practicing in Bulgaria, and he is the founder of Digital Dent, a group practice in Yambol, where he works together with a dedicated team to associate dentists and an in-office dental technician and dental assistants. Throughout his professional career, Dr. Skalidis has been actively involved in continuing education and clinical development. He has been a member of the European Society of Oral Laser Applications and Academy of Aesthetic Dentistry, and he is currently completing the EAO Master in Implantology. Over the past few years, Dr. Skalidis has focused almost exclusively on implant dentistry. And I can truly say that implantology is not just his work, but his passion. Today, he will share why Powerbone dental implant has become his safe implant of choice in daily practice, with a reported clinical success rate above 95% in his experience, especially in cases involving early or immediate loading protocols. Okay, let's start with Dr. Minas Leventis. Dr. Leventis, this is the stage is yours. Thank you for attending. Your microphone is off, please.
Okay, I fixed it. All right. Great. Thank you, Dr. Ozan, for your invitation for organizing this webinar. And thank you, Dr. Skalidis, for joining us today. My topic will be about bone regeneration and about how we can simplify and get more predictable results in our everyday cases. So what we are going to do in the next 45 minutes, we're going to try to share with you some ideas, some tools, some techniques that we are using many years now. And everything is focused on how we can get very good results with simplicity, with good predictability for our majority of the everyday cases. So we all do implants. We love dentistry and implantology. It's really an art. It's amazing. It's very important that we need to document our cases. We need good photos so we can communicate with our patients. We can communicate with our colleagues, with our lab. We can do teaching. We can do webinars. We can do research. And of course, we need to take good photos. We need to document all our cases because documentation is really a benchmark for improvement. Through the lens of our cameras, we see details, we see things that we cannot see through our eyes. So always we see how important it is to have excellent, the best documentation for the majority of our cases. Unfortunately, we don't have only good cases. We don't take only photos of successful results. We have big problems with implants. We have an epidemic of peri-implantitis. We have implants that are failing very close to finishing the treatment, or we have too many cases that we face problems several or many years after the implant is finished. And this is a serious problem. We all face it. And what we need to understand, the very important notion in our profession, in the dentistry and in medicine, is that a diagnosis, it's not an explanation. So if we just see those cases that are failing, just to focus on the problems, of course, we need to detect the problems because the sooner we find and detect the problem, maybe the best chances we have to treat the problem. But we need to explain what's happening. And only a diagnosis doesn't give us the explanation. And of course, the other notion is that always prevention is better than treatment. So what can we do? What we need a systematic way of thinking so that we can understand exactly what's happening with implants and bone grafting. So an implant is a system like everything else in life. And when we're talking about systems, we're talking about a set of interconnected, interacting, and interdependent parts, components. So all the components of the systems, they need to work together, communicate, live together to achieve a common function or a common goal. So our favorite system is the implant system. So implants, we need to understand from the beginning that they are a complex biological system. A system that comprises of hard tissues, like the bone that attaches to the implant, it surrounds the implant. We have all the mechanical components. We have the soft tissues that are not only important for aesthetics, but the soft tissues protect the implant. They ensure the long-term stability because the healthy soft tissues form the peri-implant soft tissue seal. And last but not least, this system has to do with biofilms, with oral bacteria. Whatever we do in the mouth is in the presence of oral bacteria. So all the problems we get in dentistry, the majority of the biological problems, many times they have to do with the bacteria. So we need to know all this. We need to understand all the fundamentals of the implant system. So no matter if we are at the beginning of our journey or we are experienced, always we need to go back and to see these few but very basic fundamentals that are grounded in clinical aspects, biology, and biomechanics. So what we need to know, this is exactly what we need to do good and successful implants. No one ever has become a successful implantologist just by luck. The good clinicians, they are do something always correctly. And to do something correctly, we need to do a correct implant positioning. So this is the first fundamental, the accurate positioning of the implant. Then we need to take care of the abutments, of the connections, of the hard tissues what's the quantity and, most importantly, the quality of the hard tissues that we regenerate around the implants. Very important, the soft tissues, the anatomy, the thickness, the biofilm of the soft tissues. Another fundamental aspect is the profile, the emergence profile, the cervical profile, the materials, and of course, the biofilms. So these are the fundamentals. And why it's a system? It's a system because those components, those elements, they work together. They are interconnected. So if there is a problem to one of the elements, let's say a problem with the hard tissues or with the soft tissues, or we cannot control the biofilms, then as a puzzle, we get problems to all the other aspects and we have failures. So we need to know that it is a system. We cannot ignore, we cannot replace any of those elements. And these elements, they determine the outcome and the long-term stability. So please, always when you have a problem, when it is something that you don't really understand what's happening, go back to the elements and try to figure out where we have the problem. And the implant system, it's a part of a bigger system. So the implants, they are part of the stomatographic system. And the stomatographic system, the mouth, is part of a bigger system, which is our body. So again, all these interact together. And this is what I explain to my patients when they ask me how long I will have the implant in my mouth. So I tell them that you will have the implant in your mouth healthy as long as many years that your mouth will be healthy and as long as your body is going to be healthy. Because if we place an implant and we make it perfect, and then the patient is losing teeth, so overloads the implant, or if the patient starts grinding, or we have deficiencies in vitamins, or the immune system goes down, all this can affect our implant. So always we need to see systems in front of us. We need to analyze the system. It's very effective, very simple, and can give us many, many good explanations. And of course, we see the problems, and we see the problems because systems, they deteriorate very fast. So it can take us a lot of time to plan, to rebuild the bone, to place the implant, to do the restorations. But if something happens, if we get an infection, the whole system might collapse very, very quickly. So we are talking about a science. It's a lovely science. It's amazing. It's challenging. And we're lucky nowadays because we have so many choices. We have technology, we have bone graft materials, we have digital planning, we have guides, we have amazing tools to do our job really, really good. But it's very demanding. We all know this. And we are here because we try to make this journey better, smoother, and for us and for our patients. And we need to see how we can transform this pressure from all this difficult job into clarity, confidence, and flow. So we need knowledge. So today we are going to share some very interesting things about knowledge on bone grafting. We need, of course, experience. And what else? We need very good planning. We need protocols. We always have to follow our protocols because then we need to take less decisions. So if I have protocols and I execute all the treatment steps according to my plan, according to my protocol, then I just strategically execute my treatment. It's not that I'm just open a flap and I just react to whatever I find in front of me. So very important before doing anything to have a perfect digital workflow and to make the surgery accurate, to make it safe, to see where are the nerves, where is the sinus, where are all the anatomical landmarks, where the implant is going to be placed according to the digital wax-up. So we can design the prosthetics. After designing the prosthetics, we design the implant placement. We can see everything. We can see if we will need any type of bone grafting. what will be the result, how we will do every step of the treatment. And that's the first suggestion I give to my colleagues. Do all your cases with digital workflows and surgical guides. The problem, because we are humans, we have this optimism bias. So many clinicians think that they can place freehand implants in a better way or in the same successful way, but that's not the reality. The reality in the literature is showing to us that if we don't have a guide, if we don't have a workflow, there's no way we will place the implants with the same accuracy. And of course, we have also the sunk cost fallacy bias. We think that by saving some money without the guides and the workflows, we'll make more money. But of course, we all know very well how much money we will lose if we don't place the implants correctly, if we don't have a good plan. So I strongly suggest all our cases to be guided, all our cases to have in advance a very detailed digital workflow. So from the digital planning, we can go to safe, accurate surgery and prosthetically driven outcomes. That's the best way to achieve it. If we don't place our implants correctly, then no matter what implant we are going to use, what bone graft material we are using, we'll have problems. So it's very important element, the planning and the guided positioning of the implants. And let's see a few more fundamentals, because really the success relies in simplicity and in consistency of following and respecting those fundamentals. So for me, that's my background, bone regeneration. The hard tissues, they represent one of the basics, very important aspects of implantology. The implant is going to connect, is going to integrate with hard tissues. When we load the implant, the hard tissues will start remodeling. It's an orthopedic procedure. So we need to know, we need knowledge, we need experience, we need to understand what we are doing with bone grafts and how we try to regenerate the bone. We need bone grafts, and there are too many techniques. What I advise you is to find a few techniques that work in your hands and stick to those protocols. Don't try to do everything. Don't try to use many, many different techniques, because you will not get very good experience and you will not get very good understanding with the technique and the materials. We try to use the bone grafting materials, and a very big indication, of course, is to regenerate the bone, especially after removing teeth where we have lots of bone loss, when we have big defects. And in all the cases, we need to find ways this to be as predictable and as successful as possible. I will show to you what I'm doing every day in the majority of the common everyday cases. Like this one, we have infections, we have teeth that are broken, are infected, fractures, failed root canal treatments, that they lead to localized but serious bone deficiencies. And as you can see also, we not only have lost the bone and we have a big defect, but also we have lots of bacteria, we have pathogenic bacteria, and we have an infection. We need to deal with all of those things. We need to try to be as atraumatic as possible. This is not always easy. And like in this case, that you see that it was not an easy extraction. I really damaged the soft tissues trying to remove this tooth. It wasn't easy at all. The soft tissues are damaged. You can see that the buccal plate is defective. A very big part of the buccal plate is missing. There is no bone in between the removed roots. There is no septal bone. So we just have a big bone defect. And we know very well in such cases, if we are not going to use a bone grafting material, the whole area is going to collapse. And when I will need to place my implant, I will have very few hard tissues and soft tissues. What I'm doing is I try to keep it simple. And in the majority of such cases, first I focus in removing all the infection. I need to clean the bone because if I don't remove the soft tissues, if I don't remove the infection, then the bone graft is not going to work. I use for such cases Powerbone putty. So it's a silicate beta-tricalcium phosphate synthetic paste, is osteoinductive. It's ready in the syringe. So when I clean perfectly the bone and I see that all is clean, I take the syringe, I just inject the right amount of the Powerbone putty into the defect, and I try to compress it so that the material will occupy all the defect, but it will be around 1 millimeter under the margin of the crestal bone. After doing this, we need to understand why. I want to tell you why I'm using this material. Of course, there is a variety of categories. We can use xenografts, we can use synthetics like the one I'm using, we can use from human origin allogenic, and of course, autogenous. All these materials, we need to know exactly how they work because they have different ways, different function regarding the resorption of the material and regarding their ability to regenerate new bone. And if we don't understand this, we have problems. We cannot predict how the material is going to work in the case we use it. It's like everything in life, we need to choose the right materials. If I use the right bicycle to go riding, I will have an accident, but it's not the bicycle, it's my choice. So I'm choosing synthetics, I'm choosing fully resorbable synthetics like Powerbone dental putty, because those synthetics, those calcium phosphates, will give me the best quality of regenerated bone. There is no chance, of course, with synthetics, any risk for disease transmission. And because there are synthetics, we can change the handling, we can make them to work in our hands in less invasive ways, and we can have fewer and less complicated procedures. There are synthetics, we can mold them, we can put them in a syringe, we can change their properties. And this gives us very good choices during our surgeries. This is what I'm doing, and Dr. Rozan is doing the same the last years. We focus on developing and understanding how those synthetics are working, and we have done too many publications on this area. And of course, it's not our experience, it's what we know from all the systematic reviews, is that bone quality is important, and we see that for socket grafting, the synthetics can give us excellent high quality of new bone. How we understand this? Okay, I do an extraction, I take my any bone graft material, I place it, I wait for the healing, and we can see that the X-ray shows hard tissue. We open the flap, we see that we have regenerated hard tissue. But as scientists, we need to know that different materials will give us different kinds of quality of bone. And this is important. And the only way to understand what happens with the specific bone grafting material we are using is to take a biopsy. There is no other way to measure, to see, to understand the regenerated bone quality. So in such cases, for our clinical studies, let's say in this case that we used Powerbone putty to regenerate the bone in this area, we take a trephine exactly before placing the implant. So the trephine is harvesting an amount of bone, and this is exactly regenerated bone guided by the Powerbone dental putty calcium phosphate. So we have excellent advanced histological techniques now that we cut the trephine with the bone graft, and then we analyze and we measure everything. So we can measure how much new bone we have. All this red is the new bone. So you can see that the area where we use our bone graft, the Powerbone putty, has a very large amount of new bone, around 40, 45, 50% in these cases. And because it's fully resorbable, we have a very small amount of residual graft. These particles here, the light blue that we can see here, these are the particles of the graft that is resorbing because it's a fully resorbable bone grafting material. So this is what we see in all our cases with this kind of synthetics. So to see those beautiful, excellent histological pictures, those gray particles are the particles of our bone graft. So we see that the dental patty, it's breaking down. So after 4, 5, 6 months, we see this pattern, how the material is dissolving. So we see bigger or smaller particles because they dissolve. It's a fully dissolvable material. So what happens? Why I want this to dissolve? I want the material to dissolve because by dissolving, it will give me more space for blood vessels, cells, connective tissue, and new bone. Also, by dissolving, it is becoming osteoinductive. So this material has silicate. So the particles, the gray particles, they are covered by silicate. And why we do this? We do this because silicate is charging negatively the surface of the particles, and this makes the binding extracellular matrix proteins in the area to attract more osteogenetic cells. These are the cells. Those black dots, you see how many cells are attracted in the area because of the calcium phosphate and because of the silicate that they induce osteoinduction. So to visualize this, these are the green, the extracellular matrix proteins that are attracted by the silicate, and the proteins, they guide the cells. So this protein is in the surface of the particle and is attracting the osteogenetic cells, and we can see all this guidance attraction in the area of the cells. So these cells are going to make the bone. That's the bone. So by using silicate, we attract the proteins and the cells. And by having a resorbable material, it means with the dissolution, it is releasing calcium and phosphate. So when this breaks down, we have the release of ions of calcium and phosphate. So literally, we give food to the cells. And the more calcium and the more phosphate we give to the cells, the more stem cells will become osteogenetic cells. And the osteogenetic cells, they will have a perfect environment to create a large amount of excellent quality new bone. This is how it works. This is why we use resorbable calcium phosphates, because they dissolve and they give calcium and phosphate to the cells to create lots of bone. And we use silicate because silicate will guide and attract more of these cells in the area. That's why constantly in all our research, in all our experience, and also what we see from other research, with those synthetics, if you understand them and you use them correctly in the correct indications, you will achieve the best quality of bone. Lots of research, we can send you all the papers, and we need this because we are going to place our implant. So we start from the initial situation that we have infection, we have teeth that we need to remove. So we remove the teeth. Very importantly, we need to clean the bone. If the bone is not clean, nothing is going to work, no bone graft. We place the bone graft. This is Powerbone patty. And then we have the phase of modeling. So in the next 3, 4, 5, 6 months, as I just showed to you, the bone graft will start turning into high quality bone. And then we place our implant, very important, the placement. And after placing the implant, we have the remodeling of the bone and the good quality bone starts remodeling. That's why we need these materials. That's why we need excellent quality of bone in order to get the best modeling, meaning the graft to give us the best quality of bone, and the best quality of bone will give us forever, for all the coming years, excellent remodeling. The tissue is alive, it's biomechanics, we load the tissue, so we need the best quality because the better the quality, according to Wolff's law, the better the remodeling, and good remodeling of the bone means stability of the implant. That's the whole logic. That's what I understand, that's what I apply, and it works very well in our hands. So we do our grafting with Powerbone putty. Then we need to place back the flap. And in most of the cases, we need to allow for open healing so that at the top we'll get new soft tissues just with secondary intention healing. Now, how you will protect this? You can place an Essex retainer with a tooth. You can place tissue adhesive glue. You can place a barrier membrane. There are ways you can protect the area so it will heal with open healing. Of course, we need always to control the bacteria. Always. In all the phases of healing, especially in the first post-operative days, what I'm using oxygen and lactoferrin, the blue M, because it controls the bacteria and it is speeding up the soft tissue healing. I'm not using any chlorhexidine because chlorhexidine can be toxic. We cannot use it for many days. And also chlorhexidine doesn't promote actively the healing. So we have good healing. This is after 4 months. By using the bone graft, the area didn't collapse. Of course, we have some resorption, but it's not collapsed. We have new gums. So these are the new gums that we got by open healing. And we preserved those keratinized gums, soft tissues, buccally. Considering how traumatic was the extraction, this is a good healing. And let's see what we can do now. We open our flap and we see from having just nothing. Remember, here was a big hole. There was no buccal plate. There was no septal bone. There was nothing. A very big hole, a defective buccal plate. I just used Powerbone putty. And after a few months, we see that everything is regenerated. I didn't even use a membrane. In most of such cases, I'm not using a membrane. Just clean bone with this inductive material can regenerate the area. So you can see I have very good amount and quality of bone to do my planning, to prepare my surgical guide, and to place the implant at the correct 3D position, at the correct position and at the correct depth. Because now I have the hard tissue with using the bone grafting material, controlling the bacteria and planning everything in detail. It's not complicated, but we need to check all the elements. So we created the bone with our biomaterial, we placed with our guide the implant, and now we need to think about the soft tissues and the soft tissue profile. We need to use a big abutment, and ideally we need to use anatomical abutments. This one is done with the cervical system, but there are many ways that you can design and prepare anatomical abutments. I fit the abutment onto the implant, and I just reposition the soft tissues around the abutment. So now the abutment and the anatomy of the abutment is going to guide the soft tissue healing, because it's not just the bacteria to control, it's just not just the positioning of the implant, not just the hard tissues, super important, but also the soft tissues are an important critical element. And you can see here, by doing these concepts, we just wait for the healing, just to keep everything clean. And after 3 or 4 months, we detach the anatomical abutment, and you can see how nicely now those abutments, big anatomical abutments, are guiding and conditioning the profile of the soft tissues. Everything is published. We can share with you the papers. And it's not just aesthetically pleasant, but most importantly, biologically it's good, because this emergence and cervical profile will constitute the soft tissue seal. So what's going to happen is that will not be a pocket. This will attach to the materials. That's why also the selection of materials is a critical element of the implant system. So if we have titanium and if we have polished zirconia under the gums, so if this level of the gums here is coming in contact with polished zirconia and titanium, the soft tissue, the cells are going to attach on the surface of the prosthetic materials. And by attaching, they will give us a perfect barrier, a perfect soft tissue seal, so it will keep away the bacteria from the implant. That's why we need this. This we will transfer it to the lab, and the lab will just follow the anatomy that we gave. We will have a correct, a very good restoration that fulfills all the biofunctional
Ahí tiene
requirements.
para el desayuno, chao, Josecito. Tome su.
And we fit the restoration, and because we try to have a plan, we try to respect all the elements of this implant system, we're going to have the best long-term stability regarding, of course, the implant system. Now it's up to the patient to keep it clean, to keep the mouth healthy, not to grind, and of course, to keep the body clean, because everything works together. I'm using this material in the vast majority of my everyday cases. You can use it for socket grafting. It's very predictable and effective. You can use it for, in some cases, straightforward cases with immediate placement. When we remove the tooth, we don't have any acute infection. We clean everything. We have some buccal plate, so we can place our implant and we can fill the jumping distance, the little gap here, to assist further the blood clot with these biomaterials. I'm doing it. I have excellent results. So you can see I placed my implant. Of course, again, the plan, the position is crucial. And then I fill all the area around with Powerbone putty. And then you can place your provisional. Here I didn't have lots of primary stability. So instead of a full provisional, I made an anatomical healer. So you see, I placed the anatomical healer to seal the area, to seal the bone graft, and at the same time to protect and guide the soft tissue profile. I close all the access holes with antibacterial silver plugs, and then with some composite. And then we just wait a few months, and you can see the correct placement, the correct biomaterial, this sealer, how keeps everything clean, and how we preserve the anatomy. And then the lab is going to do a restoration to get a good result. And of course, also again, very important, the selection of the materials, because we'll need the soft tissues to attach to the materials. So we'll have no pockets, we'll have a very good soft tissue seal. We have other cases. We have cases that we need every day to simplify in a predictable way scenarios like this one, that we can place the implant, but at the same time, we need to augment the ridge horizontally. There are way too many techniques and concepts and materials you can use. I want to share with you some protocols that we are working on, and we have the last 4 years excellent results. So what we are doing in such cases, like this one, that there is some concavity, there is some atrophy. We can place the implant, but we need also to augment it at the same time. So I'm placing the implant, and before placing the implant, I'm doing some drilling, some decortication, because I will need through this dense cortical plate to get more blood vessels and more cells. This is the protocol that we have developed. It's very straightforward. It's very simple and effective. We start with a site-specific flap. So you see, we do the flap in this way. So we leave the papilla. It's a papilla-sparing flap. So we go on top of the crest. We don't lift the papillas from the teeth. A small flap. Then we prepare, according to our protocol, the implant bed. In many times, because we like to place the implants subcrestally, we need to profile a bit the crestal bone. And I find it useful also to do the decortication. So these are the initial, you see, very simple steps. And now I'm using Powerbone Flex. So it is, again, a synthetic material. It's different than Powerbone patty or granules. So it's like a thick layer. It's like a fleece, you see. So I cut exactly the amount that I need according to my defect, and I position it over the bone. So this is the flex. It's PLA with silicate beta-TCP. It has this area that will go in contact to the bone, and that's what we're going to see outside. It has a denser area like a barrier membrane. And let's see how it works. So this is the Powerbone Flex. Inside, it's mimicking the natural bone. Again, it's fully synthetic, silicate beta-TCP. Outside, we have a synthetic dense layer. And through the bone, because we do the decortication, we are going to leave all the cells, the blood, to flow through the holes, through the bone, inside our layer of the flex. So I'm using this in order to do this lateral augmentation when I place the implant and when I can place a big abutment. So it's a combination of placing the implant, using the flex to augment horizontally, and also to use a large abutment to give me mechanical stability in the area. So you see after a few months that in one surgery we can fix everything. This is at loading. This is after 1 year. So this is a very predictable, simplified protocol. We can do all the procedure in less than an hour, especially if we have also a surgical guide. And we can augment the area without relying on soft tissue grafting from the palate or without using any materials from human or animal origin. Let's see another case. Exactly the same scenario. I'm using this protocol in all my everyday cases that I will place the implant. I have my workflow, and at the same time, I want, in an easy, simplified way, to correct such small horizontal atrophies. So in this premolar, I did my plan. I used a Powerbone dental implant. So these are the implants we are using now. They have excellent characteristics, and the surface is SLA, but also they come in this liquid because the surface also is plasma treated. So you can see that before packaging of the implants, all the implants have plasma treated surfaces. And again, why this is important? Because also the materials and the materials of the surface of the implant are a very important piece of the whole puzzle of the implant system. Why SLA? SLA is a very good concept because it's enhancing the macro and micro roughness of the implant surface, meaning increased bone-to-implant contact, enhancement of primary and secondary stability, and faster and more predictable integration. That's why it's SLA, the surface, and why it's plasma treated. When we do the plasma treatment, we get a cleaner surface, but also a surface that is not hydrophobic, a surface that it is hydrophilic. This is very important because if we have a hydrophilic clean surface, what happens? We have attraction of blood and proteins. So because hydrophilic, all the blood flows and is attaching to the surface and the cells, the blood clot is more stable around the implant. Because of the hydrophilicity, we have enhanced osteoblastic response, better differentiation, better adhesion of all those cells in the area. So we have improved, accelerated transition from the primary to the secondary stability. And that is going to lead, of course, in better osseointegration. That's why those implants have an SLA surface and also a plasma-treated titanium surface. So you see in this case, I had a guide here. I placed the Powerbone implant. I used a large stock Powerbone titanium abutment, but I need a large one to get the stability. Because I'm going to follow my protocol, I cut a piece of thick Powerbone flex. This is at least 2 millimeters thick. You can find also 4 millimeters or thinner according to what you want to do. So you see, I cut it. I try to not to be in contact with the margin of my flap. If you want, you can add a bit more here to support better the soft tissues. It's up to you, up to your case. You have a very big amount. If you don't like this piece, you can cut another better piece that fits better the area. You don't need to stabilize it. I just place it. I just apply it over the bone and then just to fit back the flap as possible without tension. Very good quality stitches. Just please use 5 or 6 monofilament stitches because they will attract the less biofilms. I'm using blue M gel to control the bacteria to speed up the soft tissue healing. So you see after a few days how clean everything is, how clean are the stitches. There is no irritation. It's not red. It's not swollen. It's not inflamed because we use biocompatible synthetic materials and we control the bacteria and we use good quality sutures and materials. And this is the healing after a few months. We detach the abutment, and you see with using the flex and correct positioning and the abutment, how again, following the same protocol, we did our treatment. The lab now, the best materials, titanium, polished zirconia, to fit it in this very nice soft tissue profile. And the soft tissue profile is going to create the soft tissue attachment, the soft tissue seal around our implant crown. And of course, again, because I try to control as many bacteria biofilms as possible, I seal it with antibacterial silver plugs instead of PTFE tape. So I'm sure that also inside the prosthetic canal, I have fewer biofilms and bacteria accumulation. This is the whole concept. Quickly, we do the same materials when we remove wisdom teeth, when we have different kinds of bone defects, like in this case, wisdom tooth impacted a big, we had a biopsy that was a dentigerous cyst. So we do our surgery atraumatically to remove the wisdom tooth, to remove the cyst, to clean the bone. You see it was a dentigerous cyst. And then we have many synthetic choices. Always I go for synthetics. I use the putty because it was very handy to use the syringe to fill the socket of the wisdom tooth, and all the big defect, the bone defect of the cyst, I used big synthetic silicate beta-TCP Powerbone granules to fill the defect. And I use in big defects those inductive, fully resorbable materials, because when I remove any wisdom tooth, any kind of cyst, I want to use synthetic materials that they will transform to normal native bone. Okay, that's the whole concept. Again, oxygen, blue M gel to assist the healing, to control the bacteria. That's after a few days, no inflammation, no bacteria. And that's why we use these bone grafting materials, because we will give back the anatomy of the bone, the architecture of the bone, and we will get the highest quality of new bone. So you see before, and this is 2 years after, and the big thing is that we don't have any pockets distally to the 7, so we ensure that with the new bone, we ensure the longevity of the second molar. These are our protocols. You can use the same materials for small internal lifts. I use putty when I lift the sinus, and at the same time, I'm placing my implants, because the implant will mechanically keep the membrane of the sinus high up. It will give me the tenting effect, the mechanical stability for the membrane, and the paste, the putty, will give me very quickly the highest quality of bone around the implant and inside the sinus. So please try to have protocols, try to follow steps for all your treatments. So try to plan in advance from A to Z each of your cases. Find what works in your hands, have clear, logical, predictable, simplified, and time and cost-effective protocols. This will make your work smooth, the whole implant journey as smooth as possible. So I'd like to thank you very much for your attention. And after the second lecture, we will answer to all the questions. Thank you so much.
Dr. Levantis, thank you very much for your very nice presentation. We're going to have questions for Dr. Levantis after Dr. Skalidis' presentation. Okay, Dr. Skalidis, it's your turn. The stage is yours. You can start. Thank you.
Hello, everybody. This is my Zoom. Oh. Just give me a second, please. I think not. We are okay?
Yes.
Is that right, Ozan?
Yeah, it's
Thank you
right.
very much. Hello, dear colleagues. I'm Dr. Emmanuel Skalidis. I run Digital Dents Implant Studio in Bulgaria. I'm very happy to be here with you today. Today's webinar is dedicated to Powerbone implants, and specifically why Powerbone has become my safe system when my goal is whatever dentist wants: predictable, successful implant practice with a high long-term success rate. For me, success is not only placing an implant, it's controlling the entire chain, which is the case selections, the bone quality, the surgical protocol, soft tissue management, prosthetic outcome, and patient satisfaction. Powerbone supports that workflow for me. Soft tissues management support the workflows, with the geometry that this implant has. This helps me in primary stability and surface concept design for fast early healing, which is very important when we discuss about immediate or early loading in fresh extraction socket. So in my day-to-day clinical work, my outcomes with Powerbone have been over 99 success consistently. Why? I want to thank Powerbone and the team for organizing the webinar is because he's given me the trust and the chance to share with you like a clinician to clinician why I trust a lot the Powerbone implants and where is my success is coming from. Here is a few things about me. I'm not going to say a lot about myself and where I'm practicing. Today is about successful implant dentistry in real life, not just theory for exams. And the key factors are actually decide the outcomes here. Case selection, planning, tissue handling, stability, long-term control. If you take one thing home tonight, success is not a luck, but it's a repeatable process. Success is not a talent. It's just a system that you can learn and you can repeat successfully each time. Many dentists think implantology is mainly making a hole, tightening a screw, but the bone is a living tissue. It's not a wall, it's not an engine. That's why we must trust and we must respect the two bios, biology and biomechanics. And in the real skill is not placing implants. It's making the diagnosis, planning, and choosing the right case for you. If you treat the bone like a metal, the bone will treat your implant like a foreign body. And this is something that this curve is painful, but it's true. At the very start, we all feel confident very fast. And then the reality hits us. We have failures, we have problems, and we enter to the valley of despair. The goal is not to stay there long. The goal is to climb to the slope of enlightenment and then to be in stability, to know what we're doing. In implant dentistry, confidence must follow competence and not our ego or to be just like of a hero. Real confidence doesn't come from courage. It comes from knowledge and making the right decision into every case, into every patient. Most of us started with some myths. I thought in the beginning that only surgeons can do this, or only some kind of professors, or the implantologist is just making money. There isn't the new classic one. I'll watch some online videos, I attend one course, and Monday morning I'm an implantologist. But to this webinar is the opposite mindset. Structure first, decision first, and protocols first. In implantology, the danger is, my colleagues, is not what we don't know. Of course, we don't know everything. The danger is what we think we know. And this is exactly what I was thinking in the beginning. So don't talk an implant like a plumber and don't drink the bone like a construction that I was thinking in the beginning, because the bone punishes rough. Overheating, compression, necrosis, every possible complication I have lived, I have experienced, and I have to deal with it. So implant dentistry is a controlled surgery. Calm, measured, biologically respectful, and the bone remembers your hands. So be gentle, be precise, and be disciplined, because this is a long journey, full of choices and challenges. Every step needs self-control in the protocol, and you keep adding knowledge every time. Anatomy, techniques, and how to plan. And the destination is simple. What we want, a predictable, repeatable outcomes, not to be a hero. The goal is not to place more implants, but to place implants with fewer surprises, to have our patients happy, and to have our practice every day not dealing the disaster, but be happy because the outcome is predictable, the patient is happy, and we are happy. So success is never one magic or an implant or a trick. It's a combination. First, we have to learn how to select the selection, the side factors to watch and to try to analyze, our surgical techniques and skills that every time we go better, the implant design to learn how to buy, how to choose the implant that we're going to work with. Prosthetic part, loading protocol, and of course the maintenance, which is very, very crucial. When something fails, it's usually because one link was weak, not because the implant was bad. Every failure is usually one weak link. So we strengthen the chain and never blame the implant. And this is the heart of my philosophy. Implant success starts before surgery. Design only works if the case is right. Planning is how we turn knowledge into control. And the bottom line, it's harsh but true. Good implants fail in very, very bad decisions. Most implants failures that I had, it was actually bad decisions that I made. And the decisions are trainable. I can teach, and I can teach myself to make the right decisions. So this is my mental checklist, simple and repeatable. Is this patient the right candidate for my practice? What does the implant and the site allows? What does the prosthetic results require? What is the patient expectations versus what I can give to him? Which protocol reduces risk? It's not about feeding my ego. It's about learning a way of practicing and avoid most complications before they even happened. And what is implant dentistry? Patients are looking for teeth to eat, to talk, to smile. Implants support crowns, bridges, removal prosthesis. So patients want teeth. We are planning the implants to support the teeth. Placing implants is knowing how we plant the teeth and where is the right position of the implants. Understanding what is osseointegration, the healing process, is the map to the successful practice. I will share with you as simple as possible. As a clinician, what I have to know and deeply understand. I will share with you how I have a successful implant practice the last 3 years. Why? Because I learned from my mistakes, and so I call it the theory from clinicians. Osseointegration is direct functional connection. It's not just a bone in titanium in the bone. What we're really controlling here is the environment. Yes, we can control the healing, we can control the biology, we can control by choosing the right implant surface, we can control the stability of the soft and hard tissues, and of course, we control the time. If any one of this chain is weak, the body doesn't fail, but our plan fails. So let's begin with the healing process. Drilling my colleagues in the bone is a medical trauma. So we need to understand the healing process because we can control the healing process. This is where the success starts before the biology takes over. In the phase 1, we have hemostasis. So starts with blood clot. The fibrin network that we call scaffold is very weak. So it follows the palatal release growth factors that arrive in the site and some other cells. As a clinician, I will say to you, protect the clot. Any movement, overheating, trauma can break this fragile start. So clinically, atraumatic, I like more the phrase minimal invasive treatment, surgical procedures. Stable clot, it's a better start. And a better start means fewer problems later. If you protect the clot, you protect the entire future of your implant. Inflammation is the second phase of the healing process, and this is the cleaning. These phases starts with neutrophils, macrophages that they will clean the site, they remove the debris. Okay, cytokinins after that. But what is the message to this phase as me as clinician? Control inflammation is normal. It's a part of the healing process. The danger is when it comes uncontrolled. So the dangerous is for us to be sterility, gentle handling, and minimal overheating, always to have a very good blood supply. So control the inflammation and you keep the biology working for you, not against you. The third phase is the proliferation, is where healing turns into building. Angiogenesis starts, new blood vessels, brings oxygen and nutrition. Remember, no blood supply, no bone. Osteogenic cells immigrate and attached. We have the early bone formation that we call it woven bone. So clinically, this is why I protect the biology. In my mind, always is to preserve periosteum, avoid excessive compressions, and respect the soft tissues, because you don't want to choke the blood supply. If you protect the blood supply, the bone will do the work for you. In phase 4, it's maturation. Now the body upgrades into strong lamellar bone, and we have now the biological stability. Bone remodels depending on the forces we give on it. So time is a biological partner. Early stability is mechanical. Long-term stability is biological. Load progressively, control the occlusion, and keep a very good maintenance control, the supportive peri-implant care protocol. So osteodegradation is not one single event. Bone can form around an implant in too many ways, and both matter clinically. Distal osteogenesis is in the first place. What is this? Here, the bone grows from the old bone towards to the implant. That's the classic healing direction. The body sends new bones from the walls of the socket toward the foramen surface, which is our implant. But then we have the contact osteogenesis. This means new bone forms directly on the implant surface. Think of it as the implant surface acting like a landing platform. Cell attached, start layering matrix, the bone begins right when we want it. And in real life, these two things happen together. But the faster we get the stable contact on this implant surface, the faster the integration becomes stronger. That's why in modern implants dentistry, choose hydrophilic implants because they have faster and stronger integration, and especially when the biology is protected, the results are amazing. After the early healing process, we enter the period that decides now the long-term success. This is, we talk about modeling, now we're going to talk about remodeling at maturation. The bone is not passive. Under controlled forces, it adapts. That's the so-called Wolff's law. So the loading we give influences the bone remodeling. We have three types of loading the implants. Immediate loading, which is from the day of the placement up to the 72 hours after implant placement. Early loading protocols, which are between 6 and 8 weeks after implant placement. And late loading, 4 to 6 months. This is the classic ones. This is the part that many clinicians forget. Osseointegration alone is not a finish line. When loading the implant and the crown implant function starts in the mouth, the risk of peri-implantitis begins, not in the implant placement, after we load the implant. So long-term success depends on three things: occlusion, hygiene, and maintenance. Now I want to zoom out from all of that I shared with you and see the full mechanism of osseointegration from the first blood clot to the stable integration. Everything starts with hemostasis, inflammation that is a good phase, proliferation, remodeling, and modeling. But I want you now to see this curve, which is very, very crucial. This is the stability curve. We have the primary stability, which is mechanical. But now we have the zero non-motion. That means between the third day to the 28th, let's say to the first month, we must have zero non-motion. There, if an abutment, even in a healing abutment, the patient can say it's screwed up. No, you don't touch the implant because we want this period, no motion period. At the bottom, you see the two ways of the osseointegration, the contact and the distant osteogenesis. So predictable success is not a trick, but it's a combination of the implant surface, our bone, and the biology in time, and how we control all that, and we can control every step of this. So this is something that we have seen in almost every lecture, and from I remember from my graduation. This is the Leco-Menzarsa classification about the bone. But I want to share with you, I had a question that nobody asked me. Okay, what is the difference? What is the difference between 2D and 2-3? What is the right bone, this bone or here? Okay, Professor Goran Uruk in my, when we do the classes in Malmö University in Sweden, he says, this is the best opportunity. But I keep asking, okay, and what's my training protocol? What I have to do? I'm a beginner, I want to know. Miss teaches us that these dents are tactile. Okay, but now we have some good news. Now we have CBCTs. In CBCTs, you could see that there's always in every software, we have HU. This is the Hounsfield fields. So I'm going to share you, my colleagues, that when the value is around 1,250, this is D1. If the value is around 850 and 1,250, this is D2, D3. is between 350 and 850. D4 is 150 and 350. There is, according classification of the MISE DIN5, that means there we don't have anything to do in this bone. Now I'm going to show you the strategies, drilling strategies. That means in D1, over-preparate, over-drilling, avoid compression. In D2, the standard protocol is predictable. In soft bone, we must do under-preparation. Also densification, I use it, I like it, it really helps. But it's not only that. Very soft tissue, very soft bone like D4, be careful. Slow drilling, condensation. The implant design matters here a lot. Bone tells you how much respect it needs in order to have success. And in primary stability, what you have to expect? In the first D1 and D2, expect high mechanical stability. In D3, moderate stability. It depends on your protocol and your implant macro design. And in D4, nothing is guaranteed. Don't force the torque. High torque is not success. Biology decides later for us. So in loading decisions, in day 1, in D2, you can do very safely immediate loading protocols. In D3, I suggest delayed it, not me. My practice and the mentors, they suggest do delayed or control early loading. That means after 6 weeks. In D4, delayed always is the safest way because here there is a risk management that we have. The risk in the day 1 is, D1 is what? Overcompression, necrosis, thermal necrosis. In D2, we have lowest overall risk on, but again, fibrous encapsulation, but must be there. D3, the risk of micromotion is very high. In D4, the fibrous integration and the early failure weight, this is the most common there. We must be very, very experienced with our implant. We have to know our implant very well and to have a very deep knowledge. As I say, fail a lot so you can learn. This is how I learn. And the bone density doesn't limit success. But ignoring all that, it guarantees the failure. So in torques in implanting, there are two kinds of torques, two types. We have the insertion torque. This is how the implant, during the implant placement, you can measure it with your ratchet or with your implant drilling, But it's something that I want you to understand. The final sinking torque is very crucial if you are thinking in your practice to do what the patients now they want, immediate or early loading protocols. So keep the torque in the safe zone and do the preparation to have a very nice final sinking torque. And this is where I can say fell in love with the Powerbone implant because I feel very well the insert torque and the final sinking torque, and I know safely when I can do immediate loading or late loading. So implant geometry versus primary stability. Now we move from biology to design because design is what makes biology predictable. So I'll keep it simple. We have 3: microgeometry, microgeometry, and nanogeometry. Now connect all this. Nano level, think of it as a layer that can support faster RL integration, especially during the vulnerable early weeks. The microsurface not only increases effective surface area of our implant, but also supports the early bone attachment. So macro design at the last is the body shape and the thread geometry. This is what gives us an engagement in the bone, controls the incision behavior, and sets the foundation for the primary stability. The macro designs masters more in the soft bone, in extraction sites when you want to take out the tooth and you want to place immediate implant. It's to create a surface environment that invites bone. So have this in mind. Macro gives us the stability. Micro design, micro geometry of the implant supports the contact we have with the bone, and the nano supports the biology. The clinical success happens when design, drilling protocol, and the bone quality all match in our hands. So the slide answers to a simple questions: what really matters over time after implant placement, and how the design influences. So
Macro gives us the stability, micro gives us the anchorage, and nano is purely biology. This slide is the reality check. If primary stability is weak, biology can't save us, can't save the implants, because primary stability is a mechanical lock, is what we create in the day of the implant placement. Mechanical lock is between the implant and the bone. It depends on bone density, our drilling protocol, and especially what is the geometry of the implant that we work. Micromotion decides the outcome. The reason primary stability matters is simple. It controls the micromotion. If micromotion is too high, the body cannot build bone, it builds fibrous tissue, so we have a failure. So the early weeks are not about more torque and looking to put our implant in the highest torque. It's about stability inside the no motion zone. We want this period, nothing to move. Geometry converts drilling bone into stability. Think of implant geometry as the tool that converts what we do surgically. That's why the same surgeon can get different results depending on the implant design. So here is the crossing point. Mechanical stability decreases, biological stability increases. Our job is to keep the implant stable until the biology takes over. So osseointegration is biology, but it starts with the mechanics. The macro design is the parts that you can feel every time you put an implant. It's what converts the drilling and bone into stability. We have taper implants, we have cylindric implants, we have to see the thread depth, the pitch between them, the cutting fixture, the apex design for me is very, very crucial when we choose an implant, and the apex is about guidance to the safety, especially close to sinus or to the nerves. It helps the implant sit smoothly without dangerous slipping in. So again, we want stability, but we want biology to work for us, not against us. The microtopography is what helps the implant hold on during this transition phase. The roughness increases the surface area dramatically. More area means more places for blood clot attachment, more proteins, hormone formation. It helps the early anchorage during the healing transition. This is important because stability is not constant. During the early healing transition, microtopography helps create mechanical interlocking with the early bone response. So macro gives me the start, but micro helps me survive the dangerous weeks. The nano features are where biology becomes very sensitive. This is what the cells actually read. So hydrophilic implants attracts the blood, spreads the cloth, improves the first contact with biology. In closure here, nano, it's not about torque. Why? Because if you force like the Powerbone implant in too high torque, you destroy the nano fixture. You just destroy them. You smash them in the bone. So do not use high torques. It destroys not only the nano geometry of the implant, but it destroys the protectical part. Remember that. This slide is the clinical truth. The implant is the same, the bone is not. So in dense bone, when we have dense bone, overcompression, heat can create necrosis, resorption of the bone, or delayed healing. So in dense bone, I focus on what? Thermal control, proper irrigation, and not forcing torque when I put my implant inside. In porous bone, the risk is the opposite. It's too little grip. Low engagement gives micromotion, and micromotion pushes healing towards fibrous tissue, not bone. So here, I may use under preparation when indicating. Choose the right implant geometry and manage the loading protocol after my implant's placement. Then I decided when I'm going to load my implant. So the clinical takeaway here is geometry, yes, helps, but drilling and loading protocol must match the bone. I choose the drilling protocol based on my bone quality and the tactile feedback I get when I put my implant inside to the sitting to the final position. So my goal is stability, but with biology protected, thermal control and the traffic technique are always non-negotiable. Under preparation is the tooth, yes, but only when dedicated in the soft bone. In dense bone, excessive torque is not success, it's damaging. So stability check is the torque and how you feel it. If you have ICQ, you can measure it. Put an implant on the lower jaw and with the same protocol and measure the ICQ value. And do exactly the same to the upper jaw. You will see another story, different values. And if there is a gap, protect biology and load your implant later. We have understood why the geometry works. We can give predictable primary stability. And now we understand why Powerbone implants goes perfectly for success implantology. The thread design increases bone contact and mechanical retention. The bi-directional cutting helps. The spiral flow, rounded apex, the beveled neck aims to reduce stress in the crestal area in mandibulae. Clinical takeaway home. Stability is not high torque, but stability to get there without a trauma. And that when you want to use a system consistently and to have success, you have to learn how your system behaves. This is why my Powerbone for me is the perfect implant, how I'm practicing, and I have consistently 99% success because I use all this fixture of the implant. It's a hydrophilic. I like the geometry, and I have learned in my bone how to drill and how to place it with success. The hydrophilic is very important. The colleague said it's very thorough, so I will not repeat myself and take the time of you. This is the surface behavior. Okay, this is not a magic implant, but hydrophility has very, very early and very stable osteogradation. In my practice, I have these two things. I have the reboard for plasma activating, and I have the COXO for UV cleaning. I can say to you, I use it with my other implant system that I use. I don't use it with Powerbone. Why? Because I don't need it. Because the Powerbone gives me a ready implant just to have all these plus the benefits of the hydrophilic systems without me need to buy all this technology, to lose time. And believe me, sub-blunted implant, I have clean a lot. There's times that we have to clean 2, 3, or 4 times to get a cleaning surface. Imagine this implant to take it out of the box and to put it inside. This is the failure that the risk of failure is very, very high. This is from the brochure of the implant. You can see all this. This is the benefits of the Powerbone implant, the optimum roughness, hydrophilic surface, and in preservation in this solution. They just do amazing job. So high volume clinical use is what builds real trust in the system. When you place many implants, you stop guessing and you start predicting. In my hands, Powerbone geometry has been a major contributor to predictable stability. And personally, in 2025, I installed 197 implants with 99 success rate. This is not a marketing claim, just a real daily practice. Imagine that I'm sleeping well because my patient, I don't want to get overnight and think, oh my God, I'm going to success, I'm going to have a failure. What I'm going to do. The point is not the number that I'm showing to you. The point is the consistency, that I use the same principles, I repeat it with control, I trust my hand at my implant, and I sleep well, and I have consistency and success. So the goal is here is the set the mind test. It's how you think. Success starts with decision making, not with drilling or cutting. Before we talk about threads, surfaces, torque, implant success starts before surgery. The perfect time implant design can still be a failure if the case is not right, if the patient is not right, the site is not right, or the plan is not right. So the first step is not, can I place? Of course you can place it, but should I? How I place it? Digital planning is what turns experience into control. We have now CBCTs, we have intraoral scan, we can have prosthetic driven implantology. When the end result is defined first, implant positioning becomes prosthetic driven to the perfect position, then the success is there. We are not guessing. This is how we reduce the risk. We have fewer surprises, we have more happy patients, and we sleep better. Because in the bottom line, and very, very good implants, the best implants in the world, fails in what? In bad decisions. So we protect the biology by making the right decisions early. Digital planning is the shift from guessing to sync. CBCT shows the real bone. We can know the density before we even cut. We can plan the prosthetic plan. We can have guidance if necessary. We have fewer surprises, and we can plan the cases like the pilot, not like a gambler. When you see the case clearly, you stop gambling, and then you start control the outcomes, and you know what you're doing. So my mental checklist is like Vic as a pilot. Is this patient the right candidate? What does the bone allows me to do? What does the prosthetic end result require? And which protocol reduces the risk, not my ego? So can I place an implant? No. I ask myself, should I? And if I do it, how I will do it safely? So this is the moment where implantology changes from experience and intuitions to data and control for everybody. For years, many of us were working like assumptions, tactile feel, X-rays, panoramic. I think the bone is okay. But the CBCT changes a lot. Now we have digital planning. And this is the key shift. We don't place implants where it fits, and then we will see how we'll do the prosthetic. Everything we have planned before. We have guides, we have less stress, we have fewer surprises, we have calmer surgery, we have good outcomes, happy patients, and we are very, very happy in our practice. So what you think to see now is the reality. The same implant, a different bone, different standards, but always use the same principle. Think first, plan, and cut last, after you inform, of course, very well your patient, and he's very aware about the maintenance protocol that he has to be informed before that, what he has to do. Because without the good maintenance protocol, many of these things that you're going to do, they are going to fail. And now I'm going to share with you some photos. I want to apologize about the photos. It's with my phone, but I want you to share you. I have many, many cases. I choose a few of them that I think it's very interesting for you. This is my first case. A very nice lady. She came to my office with a fracture in the second incision, 12. So what is an implant? But she says, I want a tooth. Okay. As you see here, this is the before. I took out the tooth. I do almost flapless technique. I put the implant according with the guide where it's the perfect positioning. I leave the gap. I do all the prepositions and all the protocols that you can hear in every master or advanced course. And I use the Bonegraft materials. I do it simply. This is the temporary abutment. I take one part of her tooth. I do this. Yes, a little sloppy, but it works. And how it works? Here is 3 months later. Look what's stable. Again, I'm sorry, I don't have a better photos to show you, but you can see here how good bone integration I have and what an excellent prosthetic outcome. The next case is again something that I want to show you. I have to take out the 3-1 and the 4-1 tooth and the 4-2, and we, in the beginning, we had a prosthesis up to 3-5, then we had something that will take it out, the 3-6. These things happens over the months in the real life when we have real cases. But what I wanted to show you, look when I put my implant with stability and what is around the clot. Of course, I do everything with Powerbone materials. It's the materials that I use the last 2 years only in my practice, the synthetic materials. And look now the results. The results you can see here, the soft tissue, you can see here the bone, you can see the result. We did that because we had to change. He didn't want an extra implant. I don't have an upper antagonist. This is what the patient agreed. This is what we do. The next case, I wanted to show you something that is very emotional to me. This nice lady of 76 years old came to me and he says, "Doctor, I don't want a removal prosthesis. I don't know how many years I will live. Please do something." I planned very well the cases. I told her that maybe we are going to have 2 or 3 surgeries to make in the soft tissues. Don't worry. And of course, you can understand she has a lot of problems, health problems. She takes drugs for some, doesn't have serious complications, but she's a lady of 76 years old. Of course, she's not like a younger person. So we had to take out this teeth here, and the agreement was to leave this bridge, but we are going to do a new one, and to take out the first 4 here in the front, to take out this tooth, and to give her a stability crown. This is the day of the surgery. Look what I found under it. I knew from the CBCT, but always the reality is a little bit stranger. Again, I put my implant, very good primary stability, bone graft materials, and here is the X-ray after the first surgery. Of course, we don't talk in here about immediate loading protocols and something like that. Few months later, 4 months later, because he couldn't come on 3rd month, he came on 4th month. I have to put my and place my multi-unit. So I do the 2nd stage surgery, and what I found, some defects, which is normal. And this is what I trust the material in the Minas Leveti showed you before. This is the Flexi, which saves me my life. Why? Because I just put it here. I do my suture. This is the healing abutments over multi-units. And look, what a beautiful, for a 76 years old woman, we have beautiful soft tissues, we have beautiful outcome. And this is the X-ray that I did 2 days before this webinar. Just look the bone. Just look here from the panoramic. A stable result in a patient like this. Everybody's happy, and we can have, with very easy protocols, not try to be heroes, but knowing what to do, and have faith to my Powerbone materials. I have a full success. So the next slide is another case. I don't want to, here is the plan over dentures. That means I have to clean up this mess, to put 4 implants, to have a good primary stability, to do some bone ridge here to fix in order to have then a very nice case. After 4 months, this is a stability. This is the multi-units. I put the multi-units in that time of surgery. This is the bar that I will do. This is the overdenture. This is the final outcome. Very predictable, very easy. Patient is happy, functions. I have very good stability, and now we have a very good protocol about the maintenance. The next case that I will show you, we have a bridge that there is a fracture. Again, the same. I explained to the patient that we cannot have because he has a lot of bone problems. I say no immediate protocols. Forget about this. We will think something else about the provisionals, but not immediate loading. I put the implants. The bone was really very, very harsh, very, very difficult, and we have very, very bad soft tissues. And you will see to this slide, this is after 4 months, you see that I don't have very good soft tissues. The next step here to this patient is one day to come to do some microsurgery so I can put by the golden standards, to make some soft tissues. But I hope he was coming because he says, I'm okay, I don't have pain, nothing is bleeding, and you can see here the outcome to this photo. The next case I'm going to share with you is one friend of mine, which he has very good, as I say, periodontitis. You see how we start from here. And he comes and say, I want teeth tomorrow. I cannot he's like this for years, but he wants teeth tomorrow. So I saw some things. I say, yes, we can try it. I installed 6 implants in one day. And this is what you see one day later, using it, of course, PRF. We have a very, very good healing over the first 24 hours. Here is the provisionals after 2 days. And I can say to you, until now, I'm waiting for him to come because he's not living in my town, to come and to do the final prosthesis. But as he say, everything is okay. So this is another case that we have this problem. They want teeth, they want immediate loading. We do. I always trust my Powerbone implant in primary stability. I always trust my Powerbone biomaterials to make soft tissues and hard and bone. And here is the provisionals. We don't have yet ready the final prosthetics. I try to do my best to just share with you my clinical experience, how I get from a doctor that I had, of course, my failures. I'm telling you, I have lived every failure that is possible. I have done it. I have lived it, and I have to deal with it. But now I'm constantly 99% because I have learned my lessons. I know my principles, and I have a company and implanted materials that I can trust. And thank you very much for this. So thank you very much for your attention. I hope that everything was okay, to be interesting to you, and happy to see you again in some other webinar.
Dr. Skalidis, thank you very much for your nice presentation and sharing your data with us, all the cases. These are both very interesting. And so if anybody has questions, I would like to give the stage to them. And you can ask your questions verbally, or you can write your questions so I can help you to ask your questions to our clinicians. Robert, yes.
Do you hear me?
Yes, I can hear you.
Thank you very much. I have 2 questions to the speakers. First of all, thank you very much for the presentation. It was very clear. My first question is to Dr. Levantis. You have shown us wonderful cases for the socket preservation. If you use Powerbone putty for socket preservation and you have no buccal and also lingual wall, how long do you wait for insertion for the implant in such cases?
Thank you very much for your kind words and for your question. I will wait 5 to 6 months.
Normally you wait 4 months, you said in the presentation, that's true?
In some cases, we have reopened the area after 3 months and 4 months. But if in the case I showed, it was 6 months. If I said it was 6 months, the socket graft case, that was 6 months. In the majority of my socket graft cases, I have the lingual plate. It's just the buccal plate that most of the times it's missing. And I find it very predictable even without a membrane buccally to regenerate the bone exactly as I showed in this case.
Yeah.
Now, if you feel that both lingual and buccal plates are missing, so you will have lots of mobility of the graft, then maybe we need to place a barrier membrane too.
Okay. Thank you very much. Thank you. And I have also one question to Dr. Skalidis. Thank you very much for your presentation. You have given us a detailed information about the Powerbone implant surface. Can you a little bit talk about the implant abutment connection?
The abutment connection is very, very safe. Very safe. I had exactly the same question for you in the very, very beginning before I meet the guys in Turkey when my first traveling. I fully understand you. Believe me, the Powerbone tissue titanium base and the Powerbone multi-unit abutments. I use a lot multi-unit abutment when it's not one teeth. you can see the stability that you cannot imagine. I will share with you now something as friend to friend. You know where the screws and the problems becomes very often to the prosthetical parts. When we tie a lot during the implant. When we overscrew the implant, we just don't destroy the surface of the implant. We destroy the prosthetical part. And
Yes.
after that, the hexagon is not okay. But these guys, I had exactly the same question for you in the first. They show me everything what they did, and they do amazing work with this one system. And I like that I have one to do the switching platform. That's why I almost every time, when I put the implants in the flex extraction token socket, I put in the abutment immediately. I install the abutment with 20 newtons torque immediately. And after 3 months, I just added another 10 so I can fix my prosthesis.
Oh, thank you very much. Thanks.
Okay, any other question? I'm gonna start from the chat if nobody is asking verbally. Okay, let's continue with Robert's Tegui, our distributor, UK distributor, Robert, asking to Dr. Skalidis. Thank you. We are new to the Powerbone dental implant. And what torque do you think it is appropriate for soft and hard bone? And the other question, how do you think the Powerbone implant compares to others you plasma treated yourself?
First of all, hello, Robert. Thank you for the question. He's our guru for about biomaterials, and I'm very honored for these questions from him. But I can very truly say to you, from the start of before 10 years ago, one of my mentors told me, don't try a lot of implants. Try 2 or 3 systems and work and be master to them. So the other 2 implants that I have used, I will share it with you. This is the one is the Ostem, the last years, and the Swedish from the beginning. It's a huge difference. From my first time that I put the Powerbone implant, I start to looking and to educate myself about this micro and the micro structure of the implant because I felt the difference in the upper jaw. It's amazing how I do the condensation. Of course, the drilling protocol is everything to know. But for me now that I know the 3.8, the 4.2, this is the most common, I know exactly what to do, and I just like the feeling to get inside with 20, 25 max, and in my sitting, when I get when I want, I stop. I don't try to find my 50. If I find my 50, this is in the front area when my length is near to under the nose. There I can find my 50, and there I can have immediate loading. If I don't have, I just make late or early loading at 6 or 8 weeks. In the lower jaw, it's another whole different game. There, the Powerbone that you will feel, the 3.8, 11, or the 4.2, 11 or 13, when you want to do, or 10th, of course, you will feel that the implant, you have to do very good, bigger drilling, not sub-drilling, I forgot now the word, to do more to the upper third. Then you feel how smoothly he collects some bone and the sitting torque, it starts there and you can go very easily to the 50. There, what is I do? I always over-drilling and I want to see the clot from the up. When I see the clot around my implant, I know that I'm going to have osteointegrated. That's why I said I almost every time when I have full mouth, the multi-unit, I put it to the day of the implant placement because I have very good feeling in the lower jaw, in the back. I know that I'm going to go inside to sleep in the sinus or sleep into the nerve. Exactly what is my protocol. The implant will go there. And I love the feeling to the upper jaw to D3 or D4 from the sub drilling, because you feel the stability of the implant, you feel the geometry, and you know, okay, here I am, and you stop. You're just putting the cover crew and you wait the excellent results in a few months.
Thank you, Dr. Skalidis. So Robert has another question to Dr. Leventis. He's saying, thank you for the clear slides. You explained to the group about the importance of digital planning and then a surgical guide. Do you use fully guided for all tools or pilot drill guided? His first question. And if pilot guided, do you think you lose or gain something compared to fully guidance of the full processes? And about grafting around implants, what determines your decisions to perform immediate or delayed protocol?
Thank you, Robert. Robert is a great friend. He's an excellent professional. We work together 16 years now with Robert. And yes, in the vast majority of my cases, I do the workflow and then I 3D print a pilot guide. Means that we have a guided drilling that guides a 2 mm pilot drill to the exact position and at the exact depth of drilling. So that's the most important drilling. So for my cases, I have a surgical pilot drilling guide. I do the pilot 2 mm drilling to the perfect position. Then I remove the guide and with the Powerbone drills and the stoppers, I complete the implant bed preparation according to the bone density with the normal drills from the kit. So it gives me exactly the same accuracy, and I don't see any difference. The cases where it's not my main cases, but where you really want a fully guided drilling and fully guided placement, in my experience, hands, is in aesthetic cases where you do the workflow and you have the guide, but also you have from the workflow a CAD/CAM provisional restoration. So in those cases, you need a guide that you will drill and you will place the implant fully guided because you want this to be 100% according to the workflow, because you have already the restoration and you want immediately to fit the restoration. So for the vast majority of my cases, the pilot drill surgical guide is perfect. Only for few aesthetic cases in the upper jaw that I have already a CAD/CAM provisional restoration, then there I need, and it's important to have a fully guided method and guide. So I see also the other question about your grafting arm. Yeah. What determines my decision to perform immediate or delayed protocol? I do immediate placement. In my experience, what works best in my hands is I avoid immediate implant placement if I can. Only in upper jaw aesthetic cases, I will try immediate placement when I will try also at the same time immediate loading for an aesthetic case. In all the other cases, because we can never predict exactly the pattern of healing in the next few post-extraction days, I like to do early placement or late placement. So if I remove a molar and I have a good septal bone, then I will wait just a few weeks to have the soft tissues to cover the area. And then after a few weeks, I can open the area, place the implant into the septal bone to get primary stability, and then do the grafting. If I remove the tooth, a big tooth, and I have just a big defect, no septal bone, defective buccal plate, Then I will do socket graft. So I will remove the tooth, clean everything, graft it with a Powerbone putty, and then wait, depending how big was the defect in the socket, 4, 5, or 6 months, and then just place the implant. That's how I work every day.
Okay, Minas, thank you.
Ozan, may I say something, please? Just 1 second.
Sure. Go ahead.
I want to share with the colleagues, with Minas Levedis, it's the first time that we have presentation together. But I'm very happy that for myself, because it's honor to be with a professional like Minas Levedis, like some of the audience, I'm sure they're more and more experienced doctors than me, that we all have the same principles at what I say to my presentation. Exactly as Minas said, this is what I do. Guided is the key when I need it, and it helps me only for the first drill. After that, I can do everything freehand, but I have the direction. The only thing that if I do this full guided protocols, which for me, very few cases we can have it, because first, very few cases the patients can pay, because as I say, I'm a clinician. I'm interested to have a happy practice, a profitable practice, and patients that are happy. So they just never agree to all these expensive things. So the guided is the best solution, and it keeps me safe, and I have the predictability that I want.
Also, I would like to thank you, Dr. Skalidis. It was really a pleasure to do the webinar together, and I hope it will be not the last one. And I'm very happy because through your lecture, I saw that we have the same way of thinking and we follow the same principles. And congratulations for your lecture. Thank you very much. Of course, thank you, Ozan, and your team for your amazing work with biomaterials, because you have designed all the materials. And I'm very happy for our collaboration. Thank you very much.
Thank you, Minas. Thank you for your kind words. And our German distributor wants to indicate that he's saying thank you very much for both presentations. Both were very enlightening and interesting. He's sending his greetings from Germany. And finally, Frank, our new potential distributor, we're about to sign contract in China, is saying that thank you very much for your speech. I hope that Chinese doctors can use excellent products as soon as possible. At the same time, he's also inviting you, Dr. Leventis and Dr. Skalidis, to teach Powerbone, dental implant, and biomaterials in China. Hopefully, we're gonna put it in our calendar after we finalize the registration process. We're gonna visit Mr. Frank's team and his beautiful country. I think this is all. If any other questions, please ask. If not, we're gonna finalize the webinar. I would like to thank our speakers. These are all very clear and very understandable slides and speech. Thank you very much. We are honored to work with you, and please keep yourself safe. And also, we're gonna be together in the future works. And also, I would like to thank our participants on attending at this time. So we're gonna keep doing these organizations in the near future. Thank you so much, guys.
Thank you.